Good afternoon. Welcome to Born Provincial Rounds, the very first inaugural provincial rounds from Born, Ontario. I'm going to give people another minute or so to get settled, and then we'll get started. Okay, it's 12:02, so I think it's probably reasonable to kick things off. So I do want to thank you all for attending this inaugural session of Born Provincial Rounds. This is a really big deal for everyone here at Born. As many of you know, we've spent the last 3 years working with you to develop the Born Information System. Our 5 founding members, 105 hospitals, over 80 midwifery practice groups, Newborn Screening Ontario, the prenatal screening labs, everyone has come together to build this authoritative source for maternal child health information. And we're finally at that point with the system live and operational that we get to turn our attention to really making a difference with this information. And as such, what used to be Born Ontario briefings and used to be Born Build updates, we really get to focus our time and attention on how the information in the system is being used, how the information can make a difference. The series will cross a broad array of subjects. In some cases, it'll be the work of Born Ontario, like today. But other sessions will be other groups who have used the data, used the information in the system to identify new learnings, to make new changes, some in the research sphere and others through quality improvement initiatives based on the information more locally within hospitals, LINs, things like that. So welcome, we're excited. We will be moving to sort of a more regular schedule in the new year of one Born Provincial Round per month, and we hope you'll all continue to join us on these sessions. We do always appreciate your feedback, but today I'm very excited to introduce Deshane Fell. Deshane is an epidemiologist with Born. She's been with us for a couple of years now and is in the midst of doing her PhD at McGill, and she'll be introducing the H1N1 work we were able to do on the old NIDAY database, which was one of those 5 founding members, and a great example of how the information we're collecting can be used to really make a difference. So with that, I will turn it over to Deshane.
Thank you, Mari. Can I just have someone confirm that you can hear me okay?
Yes, we can hear you, Deshane.
Okay, thank you, Anne. Okay. So I'll just get started. As you likely know, pregnant women are known to be at higher risk for a more severe illness and complications related to influenza infection. And the early evidence that we have from this came out of pandemics from the last century, actually, where there were excess maternal deaths noted during pandemics, as well as an excess of pregnancy losses. And there were a couple of pandemics in 1918-19 as well as 1957-58. And I thought this was quite interesting. This was the earliest peer-reviewed literature that I have been able to find on this topic, and this was a case series report of about 1,350 pregnant women who were infected with influenza during the 1918-19 pandemic. And this was published in the Journal of the American Medical Association in 1919, so this is almost 100 years old. But you can see at the bottom of the slide their conclusions that mortality was high, and in particular during that pandemic, about 52% of the pregnant women with influenza who had pneumonia also lost the pregnancy. So it was a very severe impact for pregnant women. So this risk, this notion of increased risk in pregnant women, has also been corroborated more recently in more contemporary observational epidemiologic studies that have also found higher risk from influenza illness in pregnant women compared with non-pregnant women in the same age. So this table here is from a Canadian study from Nova Scotia that was published in the Canadian Medical Association Journal in 2007, and it just shows in the left-hand column, even in healthy pregnant women, so women with no comorbidity, the rates of hospital admission for severe respiratory illness were higher in pregnant women in all trimesters compared with non-pregnant women the year before pregnancy. And this was particularly amplified among pregnant women who did have underlying medical comorbidities as well. And this next two slides actually just shows this information graphically. So this is in healthy, low-risk pregnant women, and you can see the increased risk of hospitalization of these women for flu during the flu season, particularly in the third trimester, and then here with the high-risk women. So in terms of the effects of maternal influenza on the developing fetus, the information we have from non-pandemic influenza seasons is a little bit unclear. Some studies did find increased risks for some adverse outcomes, and others didn't find any. There weren't a lot of studies available prior to the pandemic, and this is an extension of that Nova Scotia study I just mentioned, looking at the babies of mothers who were hospitalized with influenza in the flu season and did find an increased risk for problems related to fetal growth, so increased small for gestational age and lower mean birth weight in those babies. So because of the increased risk for maternal complications and possibly some increased risk for the fetus as well, there have been recommendations for vaccinating pregnant women against influenza for a number of years in the U.S. and in Canada. And more recently, those recommendations are for routine vaccination of all women who would be pregnant during the influenza season. However, despite those recommendations, the vaccination rates in pregnant women have typically been quite low. Prior to 2009-10, estimates from the U.S. ranged from less than 1% to about 20%, depending on the region of the U.S. And we actually didn't have any population-based estimates for Canada for pregnant women prior to the 2009-10 pandemic. And one of the thoughts as to why the rates of vaccination may have been low is because of perhaps ongoing concerns about risks regarding vaccination for the fetus, and also perhaps misconceptions about the level of risk due to illness, influenza illness in pregnant women, both on the part of mothers and possibly also care providers. But prior to the pandemic, what we knew from many years of pharmacovigilance surveillance studies is that there was no documentation of serious adverse events following seasonal influenza vaccination in pregnancy. And in fact, more recently, there's been a few studies that showed benefit not only to the pregnant women, but also to the fetus, possibly due to averted infection. And also recent evidence that there may even be transfer of antibodies from the mother to the developing fetus, which can provide some immunity to the neonate. And this is particularly important because neonates are a very high-risk group for influenza illness, but they are not eligible for vaccination in the first 6 months following birth. So this table is from the only clinical trial I'm aware of studying this topic. And here they compared pregnant women who received influenza vaccine in their pregnancy compared to a control group and found significantly reduced risk of illness even in the babies following birth. So that's the passive immunity I was just referring to, as well as reduced illness for pregnant women during their pregnancy, so among those who received vaccine compared to those who didn't. So now moving into the pandemic. And a lot has happened since then in this topic. So, as you know, in March 2009, a novel H1N1 virus was identified, and a couple of months later, the WHO declared a pandemic. And what was particularly interesting is that very early in the pandemic, there were case reports from the U.S. which documented increased morbidity and mortality in pregnant women who were infected with H1N1. And as the reports continued to come in, this was consistently an observation. So as a result of that increased risk, a number of agencies around the world, including in Canada, all recommended that pregnant women receive the H1N1 vaccine once it became available. And this is the poster that was distributed around Canada by the Society for Obstetricians and Gynecologists of Canada. So the Ontario vaccination campaign began in late October 2009, and pregnant women were targeted as a high-risk, high-priority group for receiving the vaccine. So in addition, at the same time, the Public Health Agency of Canada, as part of their response to the pandemic, made some funds available to 3 of the province-wide perinatal programs in Canada to quickly initiate some additional data collection to their routine perinatal data collection on variables related to H1N1 exposure, because so little was known about it. And in particular, although they had a national influenza surveillance system, there was very limited information available in that system on pregnant women, and particularly the outcomes for pregnant women. So with that funding, Born Ontario was able to, and this is again going back to the old founding partner, the NIDA database at that time, we were able to quickly implement data collection on 3 new elements, which began in early November 2009 and continued for 1 year. So these variables were related to influenza illness during the pregnancy, use of antiviral medication during pregnancy, as well as receipt of influenza vaccination during the pregnancy. And so these data were collected from all pregnant women who gave birth in an Ontario hospital during that 1 year time period. So I'm going to just talk to you about some of the work that we've done using these data, and we're continuing to do some other work. But these are 2 of the projects that have wrapped up and been published. So I'll go through this information with you. So the 2 objectives I'll speak about today, the first was simply to describe the characteristics of pregnant women in Ontario who decided to receive influenza vaccination during their pregnancy compared with those who did not. And then secondly was to look at the relationship between having received H1N1 vaccination specifically and some fetal and infant outcomes among singleton births. So as I mentioned, we used the NIDA perinatal database. And as of the time period that we were beginning this data collection, all of the 109 Ontario hospitals with obstetrical services were contributing to the data collection process. Unfortunately, the home births from the Ontario Midwifery Program database were not accessible to us, and so were not included in the analysis. And as you likely know, if you've used the database or you collect information for the database, there are a number of types of variables available that we were able to study, including maternal characteristics, health behaviors, and then clinical information related to the birth process. So in both cases, this was a population-based retrospective cohort study that we used to study these questions, and we were looking at live births and stillbirths over 20 weeks gestation and with a birth weight of greater than 500 grams. So this is just quickly a look at the vaccination variable that was used to collect the information during the pandemic. And so women were asked if they had received H1N1 vaccination, seasonal influenza vaccination, or some combination of the 2. So just a couple of quick methods before I start into the results. For the first objective, where we were looking to describe the characteristics of mothers who received vaccination, we included all of the women who gave birth in the first 6 months of the data collection, because that's what was available back when we started doing this work. And we calculated rates of any influenza vaccination, so H1N1 vaccination, or if they had received seasonal vaccination. And we looked at it by different maternal and pregnancy characteristics. For the other objective, where we were looking at outcomes, we limited our analysis to the singleton births, again, in that first 6 months of data collection. And we looked at fetal and infant outcomes according to H1N1 vaccination specifically. And those outcomes were preterm birth, small for gestational age, low APGAR scores, and stillbirth. And we did use multivariable regression in both of these analyses. I won't speak a lot about it, but it's particularly important, I think, for the second objective, because we did attempt to adjust for other factors which could have explained the relationships that we were observing. So as much as possible, we tried to adjust for those factors. Okay, so we'll move into the results for objective 1. This is just a flow chart showing the total number of records in that time period. We had to exclude some because we didn't have complete information on vaccination in some of the records. So basically, we were conducting this analysis on 56,454 records. So we had a nice big sample size. So this shows the rate of vaccination in those 56,000 women. So 42.6%, so about 43% of the pregnant women who delivered in that 6-month time period received influenza vaccination during their pregnancy. And you can see that the lion's share of that was, in fact, H1N1 vaccination that women received. Just a small number reported receiving only seasonal vaccine, and a few more received both. This shows the proportion of women who delivered in each of these 6 months that were vaccinated, and again showing the average across that 6-month period. So the months with the highest proportion of women delivering who had been vaccinated were December, January, February, which is really in the peak of the second wave of the pandemic. So we'll just look at a few other characteristics now, where you see a fair amount of variability. So this is looking at rates of vaccination across public health regions of the province. So you can see quite a bit of variability with highest rates in the eastern public health region at 56.6%, which is quite a bit above the Ontario average. Looking at maternal age, you can see, probably not surprisingly, increasing rates of vaccination with increasing maternal age, and quite a bit lower than the provincial average among the younger women. So women under 20, about 29% of them had received vaccination. And I should just point out the table in the bottom is just showing you an adjusted comparison for each of these rates, using the women who were 25 to 34 as a comparison group. So those that are bolded represent statistically significant relative differences in those rates, but I won't go into a lot of detail on that. I just lost my place. Give me a moment, sorry. Okay, sorry about that. So this is looking at rates of vaccination by antenatal care provider. And here you see quite a lot of variability in a few of the categories. And in particular, the women who reported that they didn't have a regular antenatal care provider had very low rates of vaccination, which is not surprising. So about 19% in women with none. The GPs had the highest rate of their patients with who had received vaccination in their pregnancy, and then fairly consistent across nurse practitioners, obstetricians, and other, little bit lower in women with midwifery care for antenatal care provider. By maternal smoking, slightly higher rate of vaccination in women who did not smoke during their pregnancy, which is probably not surprising, and this was statistically significant. And this is looking at vaccination by high-risk comorbidity. So what we mean by that is women who had insulin-dependent diabetes, non-insulin-dependent diabetes, asthma, heart disease, or chronic hypertension. And that group of women had slightly higher rates of vaccination, so about 49% compared with 42% in women without those conditions. And this is interesting because the vaccination guidelines previously were really for women with high-risk conditions only, and they were expanded to include all pregnant women a little bit more recently. So it looks like there's still a slightly higher uptake in women with those high-risk conditions. We were able to link the database to neighborhood census information using the postal code conversion file. And so the last few slides I have here are just showing you rates of vaccination by a couple of sociodemographic characteristics. So looking at neighborhood level of education, it's quite flat across the quintiles until you get to the neighborhood with the highest level of neighborhood education, where it jumps up about 10% to 50. So quite a difference in that last quintile, but otherwise fairly flat in the others. Looking now by income quintile, again, this is neighborhood level, and here you see a little bit more of a gradient, but the same general pattern with quite a bit higher vaccination rates in women who live in neighborhoods with the highest level of household income. And finally, this is showing the vaccination rate by the proportion of immigrant population in the neighborhood. So here we see the inverse. So in the lowest quintile, so the neighborhood with the lowest concentration of immigrant population, recent immigrant population, we see higher levels of vaccination, and then quite a bit lower in the upper quartile, so the neighborhood with the highest concentration of immigrants. So just a quick synopsis of what we observed in this first study. So we saw much higher rates of vaccination than have been documented in previous influenza seasons, non-pandemic seasons. So about 43% in Ontario in this study. And this compares with one of the studies that I've seen from the U.S. where they had about 47% of pregnant women were vaccinated. I don't recall if this was national or regional. But then a fair amount lower when you look at some of the other regions around the world. For example, about 37% in France, less than 10% in Western Australia, and about 13% in Denmark. And in general, in the European studies I've seen, the rates of vaccination of pregnant women are quite a bit lower. Again, we saw increasing vaccination with increasing maternal age and women with chronic health conditions. And this finding that women from neighborhoods with lower socioeconomic status had lower rates of vaccination is quite consistent, I think, with some previous studies and some that have come out of the pandemic. And certainly some of these findings, I think, are a bit worrisome because they speak to some inequities, perhaps in access to care, perhaps access to information for these women. Okay, so we'll just move now quickly through our results for the second objective, which was to look at the outcomes of mothers who had received H1N1 vaccination specifically. So again, just showing the study, the group that we looked at, same as for the first study, except that there's one final exclusion in this study, which was we only included women with a singleton birth. So for this study, we had 55,570 women. So the first outcome we looked at was the rate of preterm birth less than 37 weeks. So again, in the chart at the top, you see the absolute rate of preterm birth per 100 live births. And then in the table that is below the chart, you see the adjusted risk ratio comparing vaccinated to non-vaccinated women. And these are all adjusted for maternal age, smoking during pregnancy, neighborhood education, and neighborhood income level, household income level. And then some of them are also adjusted for other things, and for that I'll refer you to the manuscript that we've prepared. So you can see here a slightly lower absolute risk of preterm birth under 37 weeks in vaccinated mothers, although the difference, the risk ratio was not statistically significant between vaccinated and unvaccinated mothers. But when we looked at a more severe threshold of preterm birth, so very early preterm birth, which is less likely to be iatrogenic, here we see, again, much lower absolute risk of preterm birth, but the relative difference between the groups was quite a bit stronger and was statistically significant. So the adjusted risk ratio comparing vaccinated to non-vaccinated women was 0.73. We also looked at small for gestational age, first using the 10th percentile threshold. And here, again, you see this pattern of slightly lower risk in vaccinated mothers compared with non-vaccinated mothers when you look at the absolute risk. The adjusted risk ratio was 0.9, and it was statistically significant. But what's interesting, again, is when we move to a more severe threshold for identifying infants with poor growth, so using the 3rd percentile, here the absolute risk is much lower, but again, we're seeing a more extreme protective effect of the vaccine when we look at the adjusted relative or risk ratio comparing the two groups. We looked at 5-minute APGAR score, less than 7, and here really didn't observe any meaningful difference between the group. The absolute differences were pretty close, and the relative difference between the two groups was not statistically significant. And the final outcome we looked at was fetal death greater than or equal to 500 grams. And here we saw quite an interesting difference both on the absolute and the relative scale. So the risk was quite a bit lower in vaccinated mothers compared with non-vaccinated mothers, and even after adjusting for confounding factors, the adjusted risk ratio was 0.66 and was statistically significant. So this slide here is just a summary slide to kind of graphically show all of the results that I just went through. And you can see, in general, when you look at it like this, you certainly see all of the results, all of the point estimates for the risk ratios are on the left side of the dark line in the center, which is in favor of vaccination. And many of them, the confidence intervals shown in the horizontal line, is not crossing that null value. So many of them were statistically significant. So just to summarize, again, importantly, we didn't see any increased risk for any of these adverse outcomes that we studied, and this was with women who were vaccinated in their second and third trimester of pregnancy. We didn't have information on the exact timing of the vaccination, but simply by virtue of when these women gave birth and when the vaccine was available, we know they were in their second and third trimester, so we were not able to look at first trimester exposure. So to summarize, pregnant women with second and third trimester H1N1 vaccination were less likely than non-vaccinated women to have a very preterm birth, to have an SGA, a small for gestational age infant, and to have a stillbirth. So I won't go through this information in great detail, but I wanted to just position those three main findings from that outcome paper against some of the information that has been published quite recently. There have been a number of studies that have come out, especially in the last 6 months, some of which concern pre-pandemic regular kind of seasonal influenza, and then others that specifically concern the pandemic and specifically studied H1N1 vaccine as well. So with respect to preterm birth, among those pre-pandemic studies that have recently been published, several of them have also found significantly lower rates of preterm birth in women vaccinated against seasonal influenza compared with non-vaccinated women. And in those pandemic studies, specifically of H1N1, one of the papers found no effect on preterm birth. That was a Danish study. However, one study out of Sweden and another, which was reporting data from Finland and Argentina, did also find a decreased risk. None of them found an increased risk. In terms of poor fetal growth, we looked at small for gestational age as our measure, but some of the other studies also looked at low birth weight. And again, some of the pre-pandemic studies have found lower SGA rates among vaccinated women, in fact, several of them. The pandemic ones that I've seen so far have not found any decreased risk for this outcome related to vaccination. They also haven't found any increased risk, so they found a null effect, basically. And then finally, to look at stillbirth has been very difficult. There's not that many studies, partly because it's such a rare event that you need a very large study population and a high level of vaccination or exposure in order to be able to study it. So here, none of the pre-pandemic studies that I have seen recently were able to look at this outcome, but a couple of them have also been able to study it looking at H1N1 vaccination specifically. So the Swedish study found a lower risk of fetal death in vaccinated women, but it was not statistically significant. However, Pasternak, which was the Danish study, did also find a significantly reduced risk of stillbirth in vaccinated women compared with non-vaccinated, and the order of magnitude of what they observed was very similar to what we observed. I'm just going to pause for a moment because I see someone has been disconnected from the audio. Anne, could you just confirm, can you still hear me? I want to make sure it's not a problem on my end.
Hi, Deshane, it's Sandy. We can hear you fine here.
Okay, thank you. I think I'll just continue then, unless I hear otherwise. I'm just going to go by that slide. So I just wanted to say a quick word on adverse events following H1N1 vaccination. So in the U.S., the Centers for Disease Control and the Food and Drug Administration have a surveillance system that they have for monitoring adverse events of vaccination. And during the pandemic, they conducted rapid surveillance of any adverse events in pregnant women following the the licensure of the adjuvanted vaccine in the U.S. And so they did quite a detailed analysis. There were adverse events reported, but what they concluded was that for example, some of the outcomes or the adverse events were spontaneous abortion or stillbirth, but the rate of those events was actually much lower than normal background rates are in the population. So they concluded it was actually lower. And they didn't find any evidence or any concerning pattern. So their conclusion was that there was no evidence that there was anything very concerning following vaccination with H1N1. And there was also one other study, although it was conducted by the drug manufacturer itself, GlaxoSmithKline, and they did a prospective evaluation of about 267 women who they knew were pregnant when they received vaccine, and they followed them for some time, and there were no adverse pregnancy outcomes reported. So taken together, all of these results prior to the pandemic as well as now recently from post-pandemic studies, the results are certainly reassuring both for care providers and for mothers. I think most importantly, there's no evidence to date of any increased risk for preterm birth, small for gestational age, low birth weight, or stillbirth, or adverse events, as I mentioned. There's some evidence, in fact, to the contrary. There's some evidence that there's even a decreased risk for some of these birth outcomes, such as preterm birth, small for gestational age, and stillbirth, although the mechanism by which the maternal vaccine is benefiting the fetus is not well understood at this point. And I also just wanted to mention that the Danish study that was recently published is the only study I've seen that was actually able to study first trimester vaccination with H1N1, and they found no increased risk of miscarriage in their study. So just to sum up, the information from the Ontario study that I went through has been published in the American Journal of Public Health, so you can find more information if you're interested in this article online. And in fact, when it was published, as you can imagine, this topic gets a lot of interest, and it generated a lot of media interest. So we were asked to give quite a few interviews related to this study, and this one was perhaps the most exciting one when the New York Times asked if they could interview us. I also wanted to mention that the results also describing the characteristics of Ontario women who received vaccination has been accepted in the Canadian Journal of Public Health and is in press, so hopefully that will also be available over the next few months. So just very briefly, some of the strengths of this Ontario study were that it was a large number of births we were able to analyze because Ontario is such a big province. And, of course, because the vaccination rates were so high during the pandemic, because of the strong public health campaign, it really allowed us to look at some of these birth outcomes, which are thankfully quite rare, but that also makes them very difficult to study. The other thing that was really interesting with this particular influenza season in general is that it was a very virulent year. It was pregnant women were particularly impacted, and there was a very strong match between the virus and the vaccine, which kind of created the perfect opportunity for really being able to study these questions. There are, of course, though, a number of limitations, one of which is the last one and relates to my previous point, which is that the degree of benefit from vaccination is indeed specific to each season. We have a new vaccine every season. We have new viruses every season. So we may not see such a protective effect perhaps for years to come, depending on what's happening with those characteristics of the viruses that are circulating in the community and the vaccine that is available. There's also concern about a healthy vaccine effect, which is meaning that perhaps there are other characteristics of women who decide to receive vaccination in pregnancy that also make them more likely to have a better outcome of pregnancy, and this is certainly possible, although we did try to adjust for as many factors as we could that would account for that, but we may not have been able to adjust for everything. So a final conclusion, understanding characteristics of pregnant women with low uptake of influenza vaccine can certainly be helpful for future public health campaigns. it's very reassuring, again, that we haven't seen any evidence for adverse effects of H1N1 vaccination on the birth outcomes that we were able to study in this Ontario cohort. And the potential protective effects of vaccine on the fetal and infant outcomes of influenza vaccine need to be confirmed in future studies that can address not only some of those concerns about vaccinee biases that I just mentioned, but also hopefully can help to understand the biological meaning as to why it might be protective for the developing fetus as well. I'd just like to start by thanking the care providers and hospital staff in the hospitals across the province who collected these data at very short notice and probably under great duress. Also, the Maternal and Infant Health Section at the Public Health Agency of Canada that provided the funding to add these data elements to the database during the pandemic, and also to the Canadian Institutes for Health Research, who provided some funding to be able to undertake the analysis. All of the co-investigators who worked on this project, many of which you may know from Born Ontario and SPRAG, also Ning Lu, who's with the Institute for Clinical and Evaluative Sciences, Abdul Yassin, who was with the Ottawa Hospital Research Institute, Shiva Wen, Graham Smith, and Mark Walker, who are all very involved with various aspects of Born. And with that, I'll thank you, and I can take any questions.
Thanks so much, Deshane. That was a wonderful overview of a really exciting study with some valuable information for us to learn from. So you can ask questions either by writing your questions in the chat box at the top left of your screen, or else you can put your call in the queue by pressing 01. Put your question in a queue by pressing 01. You would remove your question from the queue by pressing 02, and Val will help us screen the calls, the questions that come in through calls. So we'll just give you a minute. If you have any questions for Deshane, go ahead and type them in the chat box, or put your call in the queue by pressing 01.
It's Deshane. I should also just mention, as you can see, my email is on the screen, dfell@bornontario.ca. So you're also welcome to contact me offline if you'd like, with any questions, or if you'd like any further information about the studies.
I don't see any questions in the chat box. Val, do you have anybody in the queue?
No, there are no questions in the queue.
Okay, we'll just give another minute in case anybody has anything. Just while we wait for another minute, I'll just make a comment and say that this is very timely. It was actually wonderful not only to have this presentation as the inaugural rounds for our new webinar series, and thanks so much to Deshane for taking the time in her busy schedule to do that. But it's also very timely as we head into flu season for us to be aware of the results of this study, and to make sure we share the information and take it back into our clinical settings. Here we have a question in the chat box, which is, do you have any theory about the mechanism for protection by the vaccine? Deshane.
Right, that's a great question. The theory, or the thinking as to why it might be protective, is primarily because of averted infection and then the concomitant symptoms that would cause in the mother. So if we prevent the mother becoming ill and having things like hypothermia or dehydration, some of those symptoms, that is itself going to be protective for the developing fetus. That's the theory, but no one has really been able to attack that question directly just yet to see if that's why. So hopefully over the next couple of years we'll see more research being done in this area to try and get at the meaning behind that. I'll just keep going here, Sandy. I see there's another question. Are you doing other analysis either on the full year of data or to answer other research questions? So yes, we are. We will be doing, we'll likely extend some of the analysis at least to looking at more than just the first 6 months. Part of the trick of studying influenza is that it's seasonal, and so we need to sort of look for outcomes within, let me see if I can rephrase that. You would only expect an influenza vaccine to be effective when the influenza virus is circulating in the community. So once the season is over, you shouldn't really see any protective effect of the vaccine anymore. So the latter half of the cohort that we collected information on was sort of at the tail end of the H1N1 pandemic. So the short answer is yes, we will be looking at it, but we will be sort of mindful of how this season rolled out. So we may not be able to use all of the information. The other research question we're going to try and answer over the next year is looking at longer-term health outcomes in the infants in the first year. So in particular, I mentioned the clinical trial that was done that found that infants who were born to mothers who received influenza vaccine while they were pregnant and they were born in the flu season actually had lower risk for contracting influenza after they were born. So we would like to do the same type of follow-up. We're going to look at respiratory illnesses in newborns who were born still during the pandemic and compare the rate of illness in babies whose mother were vaccinated against H1N1 compared with babies whose mothers were not vaccinated, to see if we are also able to see any sort of evidence of some sort of conferred immunity to the babies. Oh, sorry, this is another question. Will there be a coordinated public health communication campaign to tell women about safety of flu vaccine for pregnant women? That's a very good question. I'm not aware of any, but I'm probably not very tapped into the public health epidemiologists in Ontario at the moment, or what's happening through Public Health Ontario, because I'm off-site at McGill doing my PhD, so I'm a little bit out of the loop. I think that's a great question. And I see you're writing in from the Halton Health Department. So, I mean, it would be good maybe to bring some of this information to the attention of some of the folks in public health who are coordinating these campaigns if they aren't aware of some of this very recent evidence that has come out.
Thanks, Deshane. I'll just check with Val to see if there's any calls in the queue.
No, there are no questions.
Okay, thanks, Val. I think we have, those are the questions in the chat box so far. Anything from anybody else? Oh, there you go, Deshane.
Can you comment on women who experience flu-like illness? So I'm not exactly sure if I understand your question. Women who experience flu-like illness as opposed to diagnosed influenza, perhaps. I don't know, Jill, if there. Oh, sorry, no, that's a different question. I'm sorry, I'm not sure if I understand your question. I don't know if there's anything else you can put in the chat box to just clarify, and I'll just quickly go to the next question. College of Gynecologists was very Oh, okay. Thank you. So I'll try and say something about flu-like illness, influenza-like illness. I think, I mean, this is one of the challenges for sure. I think in trying to study the impact, particularly, let's say, on the developing baby in women who get ill during influenza season, because it's very difficult to disentangle women who truly have influenza and those who maybe have other respiratory illnesses or other viral illnesses. It's very difficult to measure because our measurement systems have some limitations in what they can measure. The one thing, insofar as I understand it, was during the pandemic was one time point when the testing for confirmation of H1N1, of the type of flu, was very high, I think, relative to other years. And I think there has been some work done within the Public Health Agency to sort of look at the degree to which some of our administrative data sources can be used to estimate the burden of illness, of flu illness specifically, as well as they have measures for influenza-like illness using codes in administrative data sets. But my understanding is that it was certainly a little better during the pandemic, so people who are trying to undertake research in that area may find it was a little easier in that particular flu season. I'm not sure if that answers your question, but feel free to contact me offline if you have another clarification you'd like to ask.
That looks like all the questions we have in the chat box. I'll just check back with Val again. Any calls in the queue, Val?
No, there's no calls.
Okay. Okay, well, on that note, if it looks like we have touched on all the questions that we've received, I'll just again say a great thanks to Deshane for a wonderful presentation. Thanks to all of you for signing on to our new webinar series, and stay tuned for announcements for different topics and dates to come. And we'll sign off. You have a few extra minutes for lunch, and I hope you have a great rest of the day. Thanks very much, everybody. Thanks, Deshane.
Thanks.